Junctional arrhythmias are rhythms that originate in the atrioventricular node, or AV node, rather than the sinoatrial node. They happen when the normal pacemaker of the heart slows down, fails, or can't get its impulses through to the ventricles. In those cases, the AV node steps in as a backup pacemaker. There are several types of junctional rhythms, including premature junctional complexes, junctional rhythm, non-paroxysmal junctional tachycardia, and atrioventricular nodal reentry tachycardia, also called AVNRT. Let's start with premature junctional complexes, sometimes shortened to PJCs. These are impulses that fire early from the AV node before the next normal sinus beat has a chance to get through. They're less common than premature atrial complexes, but when they do appear, they can be linked to causes like digitalis toxicity, heart failure, or coronary artery disease. On the ECG, PJCs look almost like PACs, but the P wave is the giveaway. It may be absent, it may come after the QRS, or it may come before the QRS with a PR interval shorter than 0.12 seconds. Most of the time, these early beats don't cause symptoms, and if treatment is needed for frequent PJCs, it's handled the same way as PACs, by looking for and treating the underlying cause. Next is junctional rhythm, also called idionodal rhythm. This happens when the AV node itself takes over as the heart's pacemaker. It usually occurs if the sinus node slows down from something like increased vagal tone, or if impulses just can't make it through the AV node, like in complete heart block. In a pure junctional rhythm, the rate is usually between 40 and 60 beats per minute, and both the atrial and ventricular rhythms are regular. The QRS complexes look normal most of the time, but the P waves may be absent, inverted, or hiding after the QRS. If a P wave does show up before the QRS, the PR interval will be short, less than 0.12 seconds. Because the heart is pacing more slowly, junctional rhythms can reduce cardiac output, leading to symptoms like dizziness, low blood pressure, or fatigue. Management here is the same as sinus bradycardia. If the patient is symptomatic, they may need atropine or temporary pacing to maintain cardiac output. Then we have non-paroxysmal junctional tachycardia. This rhythm looks like a junctional rhythm, but the rate is faster, usually between 70 and 120 beats per minute. It doesn't usually cause serious symptoms on its own, but it's a red flag because it often points to an underlying problem. Causes include digitalis toxicity, myocardial ischemia, hypokalemia, or even COPD. Management again focuses on identifying and correcting the underlying cause. Finally, let's talk about atrioventricular nodal reentry tachycardia, or AVNRT. This is one of the most common types of supraventricular tachycardia. It happens when an impulse gets caught in a reentry loop within the AV node, cycling through the node over and over and producing very rapid heart rates. Each time the impulse loops, it also travels down to the ventricles, so the patient experiences a fast ventricular rate as well. The heart rate can jump quickly to 150 to 250 beats per minute in the atria, and 120 to 200 beats per minute in the ventricles. The onset and offset are abrupt. It can stop and start suddenly, and the QRS is usually narrow, though it may widen if a bundle branch block is present. P waves are often hidden within the QRS and hard to see. Clinically, AVNRT can cause palpitations, restlessness, chest pain, shortness of breath, pallor, low blood pressure, and sometimes even loss of consciousness, depending on how fast and how long the rhythm lasts. In many cases, though, it's benign. The main goal of treatment is to stop the reentry circuit and relieve symptoms. For some patients, catheter ablation is the first-line therapy. By ablating the tissue in the AV node that allows the reentry loop, the circuit is eliminated and the tachycardia can't return. For acute episodes, vagal maneuvers like bearing down or coughing may help slow conduction through the AV node long enough to break the cycle. Because of the risk of stroke, carotid sinus massage is avoided in patients with carotid artery disease. If vagal maneuvers don't work, the next step is medication. A rapid IV push of adenosine is often very effective in terminating AVNRT. If adenosine doesn't work, or if the rhythm returns, IV calcium channel blockers such as verapamil, IV beta blockers, or IV digoxin may be considered. If the patient is unstable, with low blood pressure, chest pain, or altered mental status, synchronized cardioversion is the treatment of choice. If the P waves aren't visible and the rhythm has an abrupt onset, the arrhythmia may just be called supraventricular tachycardia or paroxysmal supraventricular tachycardia until it's better defined. Treatment strategies for SVT and AVNRT are the same: vagal maneuvers, adenosine, and cardioversion if necessary. So to sum up, junctional arrhythmias come in several forms, from early beats like PJCs to slow rhythms like junctional rhythm to faster ones like non-paroxysmal junctional tachycardia, and finally to rapid reentry rhythms like AVNRT. While they may be benign in some cases, others require careful assessment and treatment to maintain cardiac output and prevent complications. Recognizing their ECG features and clinical presentations is essential for guiding management and supporting patients effectively.